So our next speaker is my former resident, Dr. Courtney Phillips, who's going to talk about the focal therapy active surveillance registry, or consensus rather, sorry.
Great. It's me again. All right, I have no conflicts of interest. I am taking nominations for a title for this project because, as you can see, I'm not doing a good job.
Might as well stay.
Are we there yet? You guys have heard me talk about this. You've gotten 17,000 surveys, and I'm sure you're tired of this. We use the UCLA RAND methodology because we're running behind. I won't go super into this, but it is more statistically rigorous than using a Delphi consensus. We had a lot of participants, and before everyone falls asleep, this whole project are these people. It's not me. I just happen to be talking about it, so it couldn't have been done without all of these people. So what did we decide? We decided that active surveillance is appropriate for certain patients and that it is important to have a guideline to use as a framework, not to dictate what people do though. Certainly men aged 40 to 79 with a life expectancy of over 10 years are good candidates and can be considered for this, and certain men over the age of 80, if they're healthy, can also be considered as well. For men over the age of 80 who have a life expectancy of less than 10 years, they can be offered watchful waiting. And the role of PSA in testing with watchful waiting remained unclear. We couldn't decide what the definition of watchful waiting was. And this curve was pretty bimodal, so there's a lot of conflict there. So PSA and PSA density and derivatives should be weighed when deciding active surveillance eligibility. However, we could not determine exact cutoffs because they're different for everybody. Active surveillance can be offered to patients with less than CT2B disease and should not be offered to patients with T3 disease or higher. Certainly, select patients with grade group 1 and grade group 2 disease can be offered active surveillance, and with patients with grade group 2 disease, they should have less than 20% of pattern 4. Patients with intraductal or cribriform pattern should not be considered candidates for active surveillance. Patients with contraindications to MRI can still be offered active surveillance, and we recommend that patients undergo an MRI within 6 months, either before or after diagnosis. And ideally, these MRIs are going to be 3T MRIs, but if a patient is not a candidate for a 3T MRI, we can use a 1.5 Tesla MRI with a surface detector coil. Unsurprisingly, we have very strong feelings about how MRIs should be done. Certainly, ideally, radiologists should fulfill the ESURE criteria for experience, and if they are not read by an experienced radiologist, a trained urologist is fine. MRIs read by an inexperienced radiologist initially, ideally should be reread by ESURE criteria radiologist, and we should be using the up-to-date PIRAD score and using precise nomenclature when comparing. And we should always be comparing the MRIs to baseline MRIs. So when it comes to determining active surveillance eligibility, tumor volume is a better surrogate for tumor area or tumor greatest dimension or diameter, Extracapsular extension, seminal vesicle invasion, lymphadenopathy, and bone disease should definitely influence your eligibility, though we could not decide on a tumor volume, lesion number, or percentage of a core as far as eligibility. Genomic testing can be offered to patients who have high volume grade group 1 or low volume grade group 2 if available, and genetic testing can be offered to patients who might be at risk for heritable cancer syndrome. Neither of these is mandatory. A maximum number of cores and maximum percent of a core we couldn't decide a cutoff on this because the biopsy technique will vary in its ability to detect cancer. So contraindications to active surveillance, unsurprisingly, extracapsular extension, seminal vesicle invasion, confirmed extraprostatic extension, and distant disease are contraindications. Adverse tumor genomics and heritable germline mutations are not contraindications, but they should be discussed with the patient. So for simplicity's sake, we defined our first biopsy as our diagnostic biopsy, our second as confirmatory, and our third as surveillance. So confirmatory biopsies should be used. They should be done within 6 to 18 months. If a patient had a substandard biopsy at diagnosis, we should consider doing this sooner. If MRI fusion is not available for a confirmatory biopsy, a cognitive fusion biopsy is an acceptable alternative. And even though we've heard a lot about micro-ultrasound, we abandoned this for this particular guideline at this time due to single vendor issues. Confirmatory biopsies in a patient with a visible lesion on MRI diagnosed with a non-targeted biopsy. These patients should have a confirmatory biopsy that is targeted and has a standard 12-core biopsy. However, we couldn't decide whether patients who had been diagnosed with a visible lesion who had initially had a targeted and 12-core biopsy, whether or not they need a confirmatory biopsy. In patients who had a standard 12-core biopsy with no visible lesions on MRI, these patients do not need saturation biopsies. They do not need template mapping biopsies. We could not decide if they need another 12-core biopsy. Despite ART's impassioned plea for digital rectal exams, there was no consensus concerning the need or the timing for digital rectal exams. I'm sorry, ART. For PSAs, we should be using PSAs and PSA derivatives, and they should be checked every 6 months. Transrectal ultrasound without biopsy should not be incorporated into a protocol. Sorry. Patients with visible MRI lesions that are biopsy positive should have MRIs, and they should be done on a flexible basis depending on clinical parameters. You should consider an MRI within 2 years. Patients with biopsy negative MRI lesions should also have MRIs, and these should be done on a flexible basis as well. For patients who have no visible MRI lesions initially, they should have MRIs. We just could not agree on a frequency. There was no consensus on whether or not surveillance biopsies without a trigger or a cause should be incorporated into our protocol. So triggers for for-cause biopsy, sustained PSA increases, PSA velocity less than 3 years or an increasing PSA density, intraprostatic changes on MRI such as increase in number, size, or pyrads of lesions, extraprostatic changes, seminal vesicle invasion, extracapsular extension, lymphadenopathy, and bone lesions, changes on DRE if you're doing DREs, and again, there was no consensus on whether patient anxiety or preference should trigger a biopsy. So for-cause biopsy techniques, for-cause biopsy should include a targeted biopsy of any visible lesion and a standard 12-core biopsy. A triggered for-cause biopsy should include a standard 12-core biopsy if there are no visible lesions. Triggers for treatment without biopsy, we could not reach a consensus on whether or not patients should be treated without a biopsy, even if the biopsy would not change your management. So pathologic triggers for treatment, if you're upgraded from grade group 1 or 2 to 3, increase in the number or percent of cores with grade group 2, increase in the amount of pattern 4 in grade group 2 positive cores, or development of cribriform or intraductal pattern should trigger consideration for treatment. We could not reach consensus whether an increase in the number of cores or percent of cores with grade group 1 should trigger treatment. We did determine that mental health and/or decision conflict screening should be considered in all active surveillance candidates. And de-escalation in the rigor of active surveillance can occur if multiple clinical parameters remain stable, or the patient experiences a health event that lowers their life expectancy to less than 10 years. In patients with life expectancy less than 10 years, you should also consider watchful waiting. However, there was no consensus to whether there are clinical parameters that could prompt a change to age-appropriate PSA screening in a patient with a life expectancy greater than 10 years. If a patient has active surveillance, on active surveillance has cancer progression, refuses treatment, a provider may recommend continued active surveillance as long as they understand the risks, a second opinion, or increased frequency and rigor of active surveillance. We don't know a lot of things still. We don't know what watchful waiting is. We can't define it. Active surveillance for patients with DRE positive, biopsy positive CT2 prostate cancer, whether grade group 2 patients with 20 to 30% or 30 to 40%, pattern 4, or select patients with grade group 3 can be offered active surveillance, and do patients with visible lesions diagnosed with a targeted and standard biopsy need a confirmatory biopsy. We don't know whether patients with visible lesions need a confirmatory biopsy, and if so, what kind, and how often patients with no visible lesions on MRI should have an MRI on active surveillance. And should patients have untriggered surveillance biopsy, and if so, how often? So these are questions that I think moving forward, as we start to roll this out, we can ask ourselves, and they're routes of future study. Maybe I will send out another survey in a few years. So are we there yet? I'm not really sure, but we don't really ask when we're driving the car, but we got the car started. Thank you.